excuse me. So Jolene Singh is a student at the SUNY Downstate Medical Center, excuse me. She completed her undergraduate degree at Columbia in neuroscience and behavior with a BA. She's currently mentored by one of our own, Dr. Barthelemy at Downstate, and has done a range of different research projects in neurosurgery, as well as serving as president of the AANS medical student chapter there. She's going to be speaking to us today about HER2 expression in breast cancer metastases, in particular in non-HER2 expressing breast cancer primary patients.
Okay, great to see you all. I know that you may say Gonzalo's phone, but that's because he allowed me to use it to get audio in one of the call rooms. So I'm going to start sharing the screen with my presentation. Okay, so hopefully you can see that. So the title of this talk was Incidence of HER2 Expressing Brain Metastases in Patients with HER2 Null Breast Cancer, which is a little bit dense to understand. So I've retitled it here for you, that the goal really was to stratify patients with breast cancer brain metastases by their expected response to HER2 targeting antibody drug conjugate therapies. So the background is that brain metastasis is a major cause of mortality and morbidity in breast cancer. And breast cancer is the second most common cancer in women in the United States. And in terms of brain metastasis, you generally think about breast cancer in terms of HER2 positive, estrogen receptor, progesterone receptor positive, that's the classical way, or triple negative. And if you look at those three different segments, a third of the people who are HER2 positive, a third of those who are triple negative, and 15% of those who are hormone receptor positive, based on meta-analysis, will have a brain metastasis. So this is a significant disease burden within breast cancer. And this image, which I created, and so I'm really excited about it, is one in which you can see if you have a breast primary, what it means for it to be metastatic to the brain is that you have those breast primary cells in the brain causing the tumor. Okay, now in the clinic, what you'll see is that patients with brain metastases are routinely asking, how do drug-based therapies compare to surgery and radiation? Because there are antibody drug conjugates. You may have heard of trastuzumab. An antibody drug conjugate form of that is trastuzumab deruxtecan, which takes the trastuzumab, so that's the antibody, to HER2, and couples it, so basically binds it to deruxtecan, which is a topoisomerase 1 inhibitor. And basically the design here is because we know that it's difficult to get chemotherapies to selectively target the cells. They have a lot of off-target effects. But if you have an antibody that is specific, or as specific as possible for that tumor cell, to which you've attached that chemotherapy, it only gets taken up, and that's what you see here, into those cancer cells that are expressing that tag. And then you allow the lysosome, the cellular apparatus, to degrade that antibody drug conjugate. And once those deruxtecan molecules get released, they go into the nucleus and that DNA gets degraded. As another benefit, the lysosome, when those proteins get processed, they can go to other cells nearby and you have a bystander killing effect. So this has shown great efficacy in HER2 positive cancer. And what I'm going to share with you today is not only did it show, so first, let me start with the neurosurgery. There was a case report that showed a 31-year-old woman who's diagnosed with breast cancer in the left breast. It was HER2 positive, and she had brain metastasis. And using this trastuzumab deruxtecan, you might ask, okay, great, this works on breast cells, but does it get to the brain and pass the blood-brain barrier? And they were able to show, it's a compelling case of one, and this was in 2022, published in 2022, that there was partial response to this drug. So it does pass the blood-brain barrier and it does shrink the tumors within the brain. So this was kind of a proof of concept that these drugs could be used not just for the breast primary and metastases throughout the body, but also it can reach the brain and have some therapeutic effect there. In addition, so you might say, okay, this is just for HER2 positive cases. In addition, some work by Modi and al. At Memorial Sloan Kettering as part of the Destiny Breast 04 trial showed that HER2 low cancers also responded. So HER2 plus is generally if you have an immunohistochemistry 3+ score, If you have an immunohistochemistry 2+ or 1+ score, so 2+, these are the blue bars, you can see a decrease in the tumor size. 1+, those are the red bars. You can see that with time. So as time goes out to 120 weeks, so it's about 2 years, or 2+ years, so 100+ weeks. You can see that those tumors are shrinking on the average in both the HER2 low categories. So this is a proof of concept. Maybe this won't just work in people who are HER2 positive. This will work in other breast cancers. So what our interest was then if you can look at the HER2 primary and you look at the metastases, what's the switch rate? So could you predict from a primary, because it's easier to biopsy a breast than it is to biopsy a brain, that's brain surgery. So could we predict what the metastasis would look like? So this is just for any metastasis compared to the primary. It's not that easy to predict. This is historical data. And what we wanted to do is in our data set, so you can see the conversion rates here actually, positive to negative, so that's HER2 positive, that's 3+, can show up as negative 21% of the time, and negatives can become positive 10%. So it's less often the case of negative would become a positive from this historical data. But we wanted to assess this in patients with operable brain metastases and data that we had available within Memorial Sloan Kettering. So this was a summer project that I did with Dr. Moss over at MSKC, which we published last year. And using immunohistochemistry and in situ hybridization results, we also had access to some genetic tests in the more recent data, and expression level exome data from these patients. If we didn't have, so I compared the primary to the brain metastases, and I was able to find those that were HER2 positive, HER2 low, which I said which IHC2 and IHC1, and HER2 negative, which would be IHC0, and identify those samples, so the patients and the samples, and assess the discordance between those HER2 scores and the brain metastasis, which was assessed because they had brain surgery, they were operated on. So we had those samples to then find out what their HER2 signature was, IHC or exome or whatnot. And if I didn't have a match, so I basically try to match the cases. If I didn't have a match, they were excluded. So the final set had 50 HER2 positive samples, 59 HER2 low samples, and 23 HER2 negative samples, for a total of 132 samples that I could match within patients. And I could track the discordance, 24, 66, and 48% respectively. So one part of this is just, can I predict, based on whether the primary is HER2 positive, HER2 low, or HER2 negative, that the metastasis would be the same, or could it be different? And this is showing it could be different. And the next part, is that going to be significant in terms of it having a treatment response? Because we know from the data from the breast cancer trials that people who are both positive and low respond. And there's this open question whether people who are HER2 null will respond. So based on what I did, I looked at the data a little bit closer. And what you can see is those who are HER2 positive, you can see at different time points, sometimes they're low, sometimes they're also negative. In the HER2 low group, then sometimes they're low, sometimes they're negative, sometimes they're positive. And in the HER2 negative group, sometimes they're low, sometimes they're positive, which suggests that potentially those who are HER2 negative, either they're switching in time because there's selective pressures on the tumors, or maybe the measures that we're using are not selective enough to look at the expression, and at a different time point or at the same time point, just below the threshold of the assay, and they might be able to respond to this trastuzumab deruxtecan. And that could potentially be because deruxtecan in itself and of itself has effects on the tumor. So that's where we're going with this. Then now we're moving this into the clinical trial stage. So in conclusion, clinicians need better criteria to more reliably identify patients with HER2 low brain tumors that have the potential to respond favorably to this new HER2 targeting antibody drug conjugate therapy. And this data supports that based on looking at the discordance. And this is not discordance based on pathologists, not being able to find like 1+, 2+, 3+. So I just want to say that has been studied, and that's not what we're saying here. This is really about people being able to respond based on the fact that they have a lower expression rate. Like maybe that's just an outdated standard, or not specific enough to predict the response. So I'd like to acknowledge people who helped me do this work. And I'd like to offer one reflection that I see this type of theme, in neurosurgery all the time. I did work in epilepsy before, and in the case of tuberous sclerosis patients, where there's a genetic or underpinning to the disease, the use of like mTOR inhibitors was something that redefined how to approach, or potentially redefined how we approach it neurosurgically. In the case of neurofibromatosis, I know there was discussion about this patient who's going to the OR today. Selumetinib is one of these new drugs that is having a treatment effect and changing how we think about approaching tumors in the spine or in the periphery. So as neurosurgeons, we'll always be tasked with thinking about what's going on genetically or in terms of expression in medicine to offer patients whatever is best for their tumors. And I've had the joy of seeing that happen, like many cases. The case with Dr. Germano earlier this week, which was renal cell carcinoma with a potential hemangioma that was resected. It was cyst-like, and so forth and so on. So this has been a great learning opportunity. Thank you for your time. I'm happy to take questions.
Thanks, Jolene, for a great talk. Is there some heterogeneity in HER2 status within a single lesion, possibly? Has that been identified?
So it's possible. And so the possibility is there's time. So over a time window that can change within a single lesion, that the cells will change, and they'll just, because they've got this genomic instability, they will adopt that. And then that can also be in terms of sections. So you can think about like a sampling error. Now, in these particular cases, I said it's not like a sampling error. And I can say that because the whole tumor was looked at. So all of the tumor was kind of sectioned out. So that's one of the ways that they were able to account for that in this particular study in these samples. It's a good question. And the answer is yes.
It's interesting because we think of metastases as clonal populations of a primary, but I think the more that people do single cell analysis and other more sophisticated genetic analyses, we learn a lot more about this. But I think the goal of your study is really interesting in that, we think about simpler ways to sample tissue and lower risk ways to sample tissue. And sometimes you just don't have an option. You really do have to go for the lesion.
Absolutely.
Do we have any other questions or comments?
Yeah, Mel Proskopf in New Hampshire.
Sorry, go ahead, Jolene.
Oh no, I completely agree. And I think one of the things that astounds me is like, this is not saying that neurosurgery still doesn't have a role. Like, you still sometimes have to do neurosurgery in patients. Like, and I'm a believer in going to all these cases and seeing patients have like success with total resections. But if it's difficult or it's, not really an operable case, in this case, operable brain metastases were important because it allowed us to look at the genetic signature of the tumors. So that gave us data. But in other cases where we don't have that data and we're deciding whether we should resect or not, or do radiation, it's helpful to learn from these cases to inform those decisions. So.
Great point.
Mel
Dr.
Proskopf in New
Proskopf,
Hampshire. Yeah. Do you have any information or suggestion as to why there may or may not be a predilection to go to brain metastasis rather than just bone metastasis? A lot of her cancers will go a lot to bone, including, we see it in skull, without going and penetrating the brain. So different pathways?
Yeah, it's a great question. It's something that I'm curious about, because as you say, some of the other ways we thought about this to like look at, you said extracranial metastases, skull. Absolutely. There were cases that we have in this cohort that have that issue. And then there are people who present with their first lesion is a brain lesion. So they have a breast primary and they just have a brain lesion. We don't know what the reason is. So I think like we talked about single cell analysis, maybe we will be able to find the signatures, like what are the factors that are allowing these tumors to grow. I don't have an answer, but it's certainly an area of investigation and curiosity.
I've been surprised. I have one patient now with several skull metastases, and the MRI is totally clean inside.
Yeah, there are a lot of it can go to the vertebra, it can go to the skull. I actually had to be very careful when going through the data. Like, is this the skull? Is this the brain tissue? And really check and be diligent about.
Yeah, this patient actually presented with L4 metastasis, and now they are scattered in the thoracic and lumbar region. Also went to femoral neck and elsewhere in pelvis, as well as ribs.
Yeah. Don't know the answer, but very interesting.
Thank you.
All right, thank you, everyone. So at this time, I'm going to ask everyone who's not a health system employee or department faculty member or resident